Hi, good morning, guys, or good afternoon.
Good afternoon.
Afternoon, sir.
Great. I just in a chance for the rest of you to arrive. So I'm going to ask you to take the first 10 minutes to do those 10 MCQs. If you're logged on through the link, you should be able to manipulate the slides and run through the 10 MCQs, and we'll get back to you in about 6 minutes to get started. All right?
Is somebody moving the slide? Yeah, somebody keeps skipping, so we're not getting a chance to see the questions.
Good morning again, guys, or good afternoon again. By now, I imagine everybody would have finished looking at those MCQs. Can everybody confirm that that is the case? Hello? You guys fell asleep already on me?
No, I wasn't able to complete because the screen was moving.
Why not?
The questions, that the page was going from page 1 to page
All
2,
right,
3
so
was
let's
fluctuating.
do this. So have you finished page 1?
Right.
Sir, is there a
Hello?
way that you could, sir, is there a way that you can make it bigger? Because I'm unable to see the questions.
Can we make it bigger?
You can zoom in
All right.
yourself if you're using a laptop, as in whoever asked, if you're using your laptop, there's what you call that, like a magnifying glass looking thingy in the top left, and you use that to zoom in yourself.
In the drop-down menu, there's let me see now. But I mean, I got it bigger on my screen just by zooming on my screen.
Okay, I found it. Thank you.
Right. All right. So anybody have any challenges with question 1? No challenges with question 1? What about question 2? No challenges with question 2? What about 3? Question 3 is
Um,
clear.
for three, for 3, I was going between B and C.
I mean, I will get to the answers now. I just want to make sure you're clearly understanding the question and that there are no challenges with you reading or understanding it. All right, that's fine. So questions 4 and question 5, or 5 kind of got cut off. Which of the following are good prognostic factors in breast cancer? Estrogen receptor positivity, and the slides continue with the rest of the options on the other page. Grade, HER2 new, and so on. All right, question 6, 7, 8, and 9 are all fine, and 10 are fine, yes? And 10, of course, got cut off as well. And the last options is because of how it was loaded up in the Blackboard Collaborate. It just converted the file and cut off the pages a little bit. All right, no problem. So everybody is clear? So I should tell you a big prize awaits the person who got the most marks in this exercise. So yes, Afia, I hope it was you. We'll announce the prize at the very end of our discussion. All right. So most of you by now would have or should have completed your review of this particular topic. Examination in surgery. It's a pretty common topic. There are some stock topics that must come in every exam, and breast cancer is one of them. As you are aware by now, and you can correct me if your understanding is different here, your MCQ, your examination is going to be based solely on multiple choice questions. So whereas before, questions, short answer questions, and OSCEs, your fate is going to be determined solely on the basis of multiple choice questions. Everybody's clear on that? Yeah. All right. So I thought it best to just kind of prime you a little bit. I lifted these questions from Oxford University undergraduate website, so they're not mine. but I think they mirror in a lot of ways what we would ask you. So I just took the question, just indigenize them to make it relevant for Jamaica. I took out some of the UK statistics and so on. But the questions themselves, in terms of their structure, are not unique to what we do here at Mona or in Gayville or in St. Augustine, right? So I want to get into the main meat, though, of what I want to talk about, which is breast cancer itself. Let me just ask, first of all, if you have any specific challenges with breast cancer that you want ventilated before we get into the presentation itself. Does anybody have any challenges with breast cancer? Any challenges with your understanding of breast cancer? No? So Kellyanne Murray has a challenge with management. So we're going to spend some time, Kellyanne, in just trying to clarify your management issues. When we get to that section. And Ariane also has a challenge with management. What can you try to clarify a little bit more what you mean by a management challenge that you're having? Nelson wants to know which stage is cure and which stage is palliative treatment. Okay, that's fair. So the persons who are having management issues, what is your management challenge? Not sure what the management challenge is. I guess we'll figure it out as we go by. All right, no problem. Let's go. Let me just switch over this here. All right, I'm just trying to get to my slides here. It's proving a bit challenging, but we'll figure it out. All right. Previous life, last year I did this particular analysis of the examination in terms of the relative failure rate. The slide is still relevant. It is indicating that the failure rate it is going to be somewhere around here, around 5%, right? Somewhere around there. So, however, there have been a few years when the failure rates have gone really, really high, up to as much as 16 and 17%, and those are considered outliers. But generally speaking, the failure rate for these examinations are usually quite low. So I wouldn't worry about anybody here failing. I'm sure nobody in this group of 35 students belong in the bottom 5% percentile of the class. So I don't expect any body to have a challenge with this examination, and specifically not with issues surrounding breast cancer, at least not after we are done today. Those numbers are important. It's just the details of the analysis, but it is less relevant for you at the moment, right? Less relevant for you at the moment because the format of the exam has really changed so radically because of the COVID situation that it's hard for me to make sense of to guide you properly as to how to strategize for this exam, because they're all MCQs. So a different strategy we're gonna have to employ. One of the things you have to bear in mind though is when you get into the exam, look how many MCQs you have, look how much time you have available to do the MCQs, and then after you look at the time for the MCQs, figure out how much time you have for each MCQ. The tendency is to think that you have about a minute per MCQ. But in the previous incarnation of the exam, it turned out you only have about 0.75 minutes, so 3/4 of a minute, a little over 3/4 of a minute, in order to 3/4 of a minute to answer the question, right? Because of how the breakdown of the exam was. I'm not entirely sure what the breakdown is going to be this time around. What you have to do is get in there, do your analysis as you're preparing for the exam, see how much MCQ you have, see how much time you have available, do your rough calculation, see how much time you need to allocate to each MCQ. And if you see the time is running by, just move on to the next MCQ. At the end of the process, just having to put C as your response to all of the questions because you just didn't finish question. I found something interesting. In the last examination, the post-COVID, you had about 80 seconds to do each MCQ because of the 90 MCQs that were required in 120 minutes. So I'm not sure. I think this is going to be the same format for this examination, and I think you're going to be okay if you spend about this time on it. I remember when I was looking at those MCQs from Oxford University for you just now, I was running through the questions very quickly. And at the end of the day, I got one of them wrong, and I just couldn't quite figure out. I mean, like, how could I get an undergraduate question wrong? I was furious with myself. So I can check the answer. You know what? It turned out the problem was I misread the question. So it occurs at every stage of life. And I just couldn't quite figure out how a person as seasoned as myself, who has been doing MCQs for so long, could misread a question so disastrously and got it wrong. But it happens. So you have to bear in mind all of this and go through, read your questions properly, and give yourself enough time to think about the questions without dwelling too much on it. If it's something you don't know, and you're obviously not going to figure it out in any in a short piece of time, just move on to the next question, and then you can come back later on and signpost it. Come back to it if you find yourself with some extra time at the end. And when the exam is done, it's done. Don't postmortem it. All right. Let us go. So breast cancer is what we want to talk about. And if breast cancer looked like this, then it would be very easy to diagnose. It would be very easy to figure out what to do with it, right? But unfortunately, it often doesn't look like that at all. And it looks more like this. It's just a altogether devastating diagnosis that when it affects you, it makes it seem as if your entire world and universe is collapsing for the persons who are affected by it. So we want to provide some relevant information on breast cancer to you. We want to talk about exam relevant stuff as well. And I want to allow you to know that you can interrupt me at any time to ask your question. So if at any point you have a question, just put it in the chat or just shout and we will get to it. All right? So don't be shy about that. Now, where was I? So worldwide, we're talking about a million women. Most of them are being affected by breast cancer. These numbers have changed a little bit in the last 10 years, but the number is about 40,000 or more persons dying per year with breast cancer out of about 200,000 diagnosed. So the lifetime risk is going to be somewhere between 1 in 8 and 1 in 12, depending on your particular genetic makeup and the society that you live in. So in Jamaica, it's about 43 per 100,000 population per year, which makes it the #1 cancer. It has passed out cervical cancer, principally because of things like pap smear, more access to screening, and then HIV as well as reduce the risk of cervical cancer. And then things like your Gardasil vaccinations against HPV, those factors have reduced the rate of cervical cancer, and therefore breast cancer has risen now to be the #1 cancer in the population. If you go to places like Trinidad, that number is about 78. So it's reasonably low in Jamaica. It's higher than this in Barbados, higher than in Bahamas, and so on. But the fact is that it's about 1 in 8 to about 1 in 12 lifetime risk over the patient life. I don't need to remind you at all about things like anatomy. You know where the breast is located, you know the layers that it's located in. It's going to be above pectoralis fascia and below the deep fascia of the body wall. And there's this modified gland that sits in that particular area. You have lobules, you have ducts, and of course you have different parts of the ducts, like the lactiferous duct running in the subareolar area, lactiferous sinus, which is where most of the introductal papilloma is, and so on. You would be able to appreciate, of course, that almost all breasts are the same size. That in terms of the glandular elements of the breasts, the lobules, the ducts, and so on, most breasts are exactly the same size. You have about 12 to 15 ducts that opening out on the nipple or close to the nipple. And the difference between a size AA breast and a size, I don't know, triple D, is there such a thing? I don't know, H, is just the amount of fat, the amount of subcutaneous fat in the breast, and the amount of fat that is interlaced within the ducts and lobules that gives it its particular shape and size. But all of them are basically the same breast tissue mass, one versus the other, right? In terms of the functions of the breast, you would appreciate that breastfeeding, it's, at least for some, the #1 function. But if we should only restrict the function of the breast to breastfeeding, we would be able to easily manage breast cancer. We would just cut off all breasts at the end of reproductive careers at age 40 or whatever the number is, and would have avoided breast cancer. But obviously, we need the breast for other things as well. It's a part of your personality and character and structure, and for some people, it's a part of their livelihood. Obviously, for some people, that's how it's an important secondary sexual organ, if not primary. So we can't just cut it off, is the point I'm making, right? We have to respect that the breast has different functions and it needs to stay there as long as possible to carry out its many functions. In terms of what breast cancer is, it's basically tissue that starts in the breast. We know that there are different subtypes, there are ductal and lobular types, and this is just for descriptive purpose only. It is not really true, right? That it starts in the tubes. It really just how it appears histologically on the slides, that you can say, well, this is ductal or this is lobular, because something that appears in the lobule can actually look like ductal on microscopy in the pathology lab. All right. So although this is a clearer understanding, a clearer description, we have to bear in mind that it is not really the truest description. In terms of the in situ forms of the disease, we know that if the basement membrane is not breached, then it's going to be a ductal or lobular in situ. Whereas if the basement membrane is breached, we're talking about invasive cancer. So you have to kind of understand those terminologies. We have to know in this day and age about the effect of hormones and breast cancer. We know that estrogen is a risk factor for breast cancer because estrogen itself promotes the growth of breast tissue and similarly promotes the growth of some breast cancers, specifically breast cancers that are estrogen receptor positive. You also know that the progesterones can also increase tumor growth if they are progesterone receptor positive. And generally, most tumors that are estrogen receptor positive are progesterone receptor positive, but that's not always the case. HER2/neu is something that we have to know about. It's a specific gene that increases breast cancer growth. And therefore, patients with HER2/neu gene positivity, overexpression, generally have more aggressive disease, right? generally have more aggressive disease. However, if you have enough money, then the patient can do better having a HER2 positive cancer because there is a drug, trastuzumab, that can block the effect of that particular gene. So although generally, if you have a HER2 new gene, you have a more aggressive cancer, because you have a drug that can block the gene, your outcome is going to be better if you have enough money to afford this particular drug. Of course, in the current dispensation, you have to know about BRCA1 and 2, BRCA1, BRCA2, and because these have adopted a more mainstream significance in more recent times. We know it's pretty uncommon. About 0.1% of the US populations carry this particular breast cancer gene, 1 or 2. And it's only about 4% of breast cancers today really have BRCA1 or 2. In the Jewish population, specifically Ashkenazi Jew, about 1% of them, so about 10 times more, will have breast cancer gene 1 or 2. So in Jamaica, they did a study. Had abnormalities in the gene, but not only breast cancer 1 or 2, but also PALB2. It's another gene that can cause breast cancer as well. So not very different from the American figures. There's a paper out of Bahamas. Anybody from Bahamas in the group? There's a paper out of Bahamas done in Berg et al. Recently done in the last 10 years or so, that spoke to a 23% prevalence of BRCA1 gene in breast cancer patients. I don't know if I believe this. I would imagine, if it were so, that breast cancer ought to be more devastating and more deadly in the Bahamas than anywhere else, because this rate of 23% is 5 times higher than the rate even in the US, where it is fairly high. So I'm not sure what to make of the paper. I need more information about it. But just in case it comes up in your discussion, you can speak to the fact that BRCA1 is said to be way more common in Bahamian population than in other population. So those who have these particular genes tend to have more aggressive looking breast cancer that are ER and PR negative, and tend to develop breast cancer in about 70 to 80% of the times. So the range is about 50 to 80% of lifetime risk of the development of cancer. And therefore, prophylactic mastectomy is a rational approach. It's an option for managing patients with BRCA1 or BRCA2 breast cancer. Of course, it's not the only approach. Another very rational approach is to just do aggressive surveillance utilizing a mammogram and MRI. So we do a mammogram every year, MRI every year, and stagger them every 6 months. So at least every 6 months, the breast is being evaluated by some methodology that allows you to be able to early pick up breast cancer and then act accordingly. So although the lifetime risk is 70%, you still have a 30% chance that you will not develop breast cancer. Some people want to hold on to that, and the way to hold on to that is to do aggressive surveillance for the breast cancer. Many of you here will know about Ms. Jolie, Angelina Jolie, who had BRCA, I think it was 1. Give me 1 second, guys. I have an important call coming in. Hold your thoughts. Hello? All right, guys, sorry about that. Breaking transmission. Let's resume. So you would have heard of the Angelina effect. She had breast cancer. Actually, no, she had BRCA1 and decided to do bilateral prophylactic mastectomy with reconstruction. So many women will similarly, or have in fact similarly been requesting this particular option. We tend not to offer it though unless a person has a proven BRCA1 or BRCA2 or other genes, because there are other genes as well that will increase the risk of breast cancer. We spoke about P10, TP53, and so on. There are many other CDH1 which can increase your risk of breast cancer similarly. So if there's a known gene that can increase your risk of breast cancer beyond 50%, say, then it is reasonable to offer prophylactic bilateral mastectomy. If there's no known gene, but there's just, say, a strong family history, or the patient just has a desire for it, then that is not as clear-cut a request and not as clear-cut an action that you need to take. I want to be clear about this. So only in patients who have a known genetic risk factor do we offer bilateral prophylactic mastectomy. Other patients may request it, but we have to delve into a deeper discussion about that. But we don't routinely offer it to patients who don't have a genetic risk factor. In terms of the risk factors, other risk factors, we know there are unmodifiable factors like your age and your gender and your race, and other facts of your life, like if you have had radiation exposure, if you have had previous breast cancer, we know there's a risk of 1 to 2% per year risk of developing breast cancer in the ipsilateral scar or breast or the contralateral breast. If you have a strong family history, then that is going to increase your risk by about 30%. In terms of your menstrual cycle, what we're really talking about here is if you have started menarche early, so pre-12, and if you have had late menopause, meaning there's more time, there's more duration of time that the breasts were exposed to estrogen during your fertile period. So your risk of breast cancer is going to go up quite substantially. In terms of your modifiable risk factors, the factors that you can control, well, reproduction is one of those factors. You can always start having babies early if you want, pre-35, and have as many as you want. And it is parity, though, that gets the protection. So if you have been pregnant 10 times and had 10 therapeutic abortions in the first trimester, it doesn't appear as if the break in the estrogen surge is enough to give you any kind of protection for breast cancer. But if you take that child to parity, meaning 28 weeks in the old definition, then you get the benefit. Breastfeeding reduces the risk. Alcohol and tobacco increase the risk of everything. Hormone replacement therapy also increase the risk for the development of breast cancer. Obesity is a little bit more controversial. There's the controversy really.
Dr. Powell,
Yes, go ahead.
clarification on something. Does
Yeah, go ahead.
smoking increase the risk?
Yes, but it's not an effect specific to breast cancer. It's an effect seen in every cancer.
Okay, and does drinking increase the risk also?
Yes, and again, similar reason, right? Because of how
Okay.
right. So it's not necessarily something seen in breast cancer uniquely. There's an increased risk in all different types of cancer. So I was explaining the controversies around obesity, because obesity tends to reduce the ability to detect the breast cancer, because if the breasts are very large, it's hard to find a 1 centimeter marble in a very large size K breast, right? As you know, the size is really just fat. So certainly women who have very large breasts will tend to present later with later stage breast cancer, larger tumors, and metastatic disease and so on. But it's also the case that you can actually produce a fair amount of estrogen by conversion of the peripheral fat, steroids in the peripheral fat to estrogen, which can therefore increase your estrogen surge and therefore increase your risk of breast cancer. Certainly that latter theory is a little bit more controversial, but certainly the former, as far as detection, is more mainstream. And we spoke about radiation increasing your risk. Certainly even radiation for treatment of breast cancer in the contralateral breast will increase your risk for development of cancer in the other breast. Now, you might have read somewhere that if you have had a biopsy before, then your breast cancer risk increases. Have you ever heard this statement before? Yeah, Nelson, yeah, okay, how do you explain that? So Robin Edwards says lead time bias. What do you mean by that? Or what do you understand by that?
What I understand from that is basically that um, there's earlier detection, so it appears as though there's like an increased incidence, but it's just that it was found earlier than it would have been had there not been testing for it.
Okay, true. But this is a little bit different what I'm asking, because what I'm asking is about the fact that you might have had a biopsy and the biopsy was not breast cancer, right? Not that the biopsy showed breast cancer, but just the fact of having had a biopsy puts you in a higher statistical risk category for the development of breast cancer. And the temptation is to believe that it is a biopsy itself that is increasing your risk. Somehow it's the surgery or the sutures or whatever you use. But what it is really is that the fact that you had a lesion in the breast that turned out histologies that increase your risk of breast cancer, that is really the issue. So if you have had proliferative disease, especially with atypia, or and especially with a strong family history, or if you have had atypical ductal or lobular hyperplasia, all of these are things or histologies whilst they are not breast cancer, will increase your relative risk of development of breast cancer, right? And so it is the presence of these other non-cancer histologies on previous biopsies which statistically increases your risk of breast cancer, if you understand what I mean. If you don't understand, you need to let me know right away. All right? And these are kind of the relative risk calculation. Does anybody understand what a relative risk Summer? Let me ask you this question, right, Summer. Does anybody understand what a relative risk of 1.3 means? What does a relative risk of 1.3 really mean?
I'm not sure, sir, but I was asking to, if you could
Come again?
explain.
I'm not following you. Hello?
Dr. Paul,
Yes.
does it mean you have a 30% risk of getting it compared to the average person or the person without that
Correct.
risk?
Correct. So it's a 30% risk. All right. So a
Okay.
non-proliferative breast disease, for example, the relative risk of 1 means that it is the same as the general population. Whereas a relative risk of 1.3 to 1.9 means you're about 30% to 90% more likely to get the breast cancer as opposed to 900% here, if you had a strong family history. All right, somebody had a question. I get the impression I didn't respond to it. What was the question?
Sir, it's in the chat.
It's in the chat? Okay. But you can still ask me so everybody else can benefit from it if they don't want to toggle between the chat and what
Sir,
was the question? Voice the question.
there's bad feedback when I speak. Like I can't hear myself. It's echoing.
Okay. I'm not sure what the cause of that. I'm hearing you very clearly. But what was your question? Did you have a question? You were asking me to re-explain what I was just saying. What do you want re-explained? Clarify, please. I'm not hearing you. All
Dr.
right.
Paul, I think it was where you were talking about the reason behind the malignancy after doing the biopsy. You were
Right.
breaking up.
Oh, I apologize for that. So all I was saying is that issue really is that you had a biopsy that showed some histology that whilst it is not breast cancer, the histology may increase your risk for development of breast cancer. That's all we were saying. All right. But the issue is that some persons, I've heard it theorized that it's the biopsy itself, the act of the biopsy, that increases the risk. And it's not really the act of the biopsy, but perhaps the reason why you had a biopsy in the first instance that puts you in a statistically higher risk of breast cancer development.
Sir, what I was asking, the question was,
Yes.
sorry, my laptop was dying. I was asking if it was a precursor lesion of sorts, why it would increase the risk.
If it's a precursor lesion, well,
Yes.
some of the lesions, like your typical lobular hyperplasia or so on, but not necessarily. It's not necessarily a precursor in the usual sense, like you would understand a precursor for like colon cancer, as in a polyp becoming a cancer. It's a separate histological subtype altogether, but your risk is increased because once you develop this particular histological subtype, you can then go on to develop breast cancer from separate cell lines. So it's not precursor in the usual way in which you understand precursor as in a stepwise development of breast cancer.
Okay, I understand.
Okay. And of course, perhaps the only one of these worthy of consideration is meat, because you would be aware that meat increases the risk of development of some kind of cancers. Any kind of cancer, anybody know which kind of cancer is increased with meat? No? Well, colon cancer. So, yeah, yes, Richard, colon cancer. So it's important that we try to demystify some of these things surrounding breast cancer and just focus on what we know to be true about breast cancer development. All right. In this day and age, of course, you have to know something about risk models for breast cancer development, among which is the Gale model is perhaps the most common risk calculated model. I don't expect you to know the various ins and outs of the model. I expect you to know that there are these models, which when you plug some variable in, just look them up on your smartphone. When you plug these variables into the model, it will give you a relative risk calculation. And you can use that relative risk calculation in order to try to figure out, okay, is my risk of breast cancer development an average risk, in which case do I screen a particular way, or do I have a high risk of breast cancer development, meaning you have to screen in a different way than the regular population? Or, so it can guide the individual and guide the clinicians as to how to advise individuals as to how to manage certain types of breast diseases based on their risk of breast cancer development. And of course, you have different models that are more applicable to different situations. So persons who have genetic risk factors will utilize other models like the Claus model, or there's a BRCA model as well for persons who are BRCA positive as well. So the point is that there are these different models that you have to figure out which is relevant in which situation. Gale is more for the general population. How do you diagnose a condition? Well, you take a history, do a physical examination, and you do some diagnostic tests. Your 3 pillars of diagnosis as ever, right? In terms of your history, unfortunately, the history is not a good thing to rely on because there are really no early signs and no early symptoms of breast cancer. Most times it's going to pass unnoticed, and that is why you have to really go looking for breast cancer. When you do get an early-ish sign, you're going to get a lump or perhaps some other changes in the contour of the breast, maybe some unfortunate-looking nipple discharge as well. Later on, this is when the horse has already bolted. You might get things like pain in the breasts from skin infiltration or nerve infiltration, or bone pain from metastatic disease, or when you start getting ulceration, fungation, then it's really, really a very late sign. Arm swelling is usually indicative of lymphatic channel infiltration in the axilla. Again, pretty late. Weight loss, talking about constitutional symptoms secondary to metastatic disease. Again, way late, right? So the vast majority of signs and or symptoms are going to occur in breast cancer late. And that is why looking for these things is going to be important. You have to know a lot about the various diagnostic modalities that we have available to us. Ultrasound, mammogram, the main one, MRI, PET scan, CT scan, etc., etc., etc. All of those you need to know about. You need to know a little bit about them so you can know how to apply the technology in the various situation that you find yourself. All right. So early detection, mammography has been shown to reduce mortality quite substantially. And these figures have improved over time. These figures are maybe about 5 years out of date. Currently, the risk reduction overall is going to be about 30%. But as you can see, it's not very good, especially in the younger age group. It's not very good. Older, as the breast tissue, the glandular elements of the breast become more replaced with fat, the sensitivity to mammogram for detection of breast cancer increases, and therefore it is more accurate in younger patients. Which is why we start using some other modalities in younger patients, but they're not really approved for that application quite as yet. In terms of what could come, we can show you mammographic images in your MCQs, because we can do an interactive MCQ and we can ask you to comment on it. And just in terms of your life going forward, we might be able to show images at your level. If it's going to come though, it's going to be something quite obvious, like this. What do you think is going on here? Is this normal or abnormal? I mean, it's clearly abnormal, right? But it is not cancer, that's the point. These are just calcifications in benign fibroadenomas, just calcifications along some ducts. So these are all abnormalities in the breast, but not likely to be malignant. Big popcorns in the breast tissue, massive macrocalcifications, again, not likely to be cancerous. As opposed to here, where you now start getting architectural distortion. If you look at this part of the breast, you can see that there is obviously a mass that is spiculated. You have it infiltrating, you can almost see it infiltrating the surrounding tissue, and you can almost see the nipple becoming retracted here, right? So, so this is an example of infiltrating cancer. No calcification, but still highly suspicious for breast cancer. As opposed to this one now, where you can definitely see that there is going to be microcalcification occurring, along with an increased density in the breast as well. So these are the kinds of things that we could ask you, and it will be something as obvious as this, if you're going to ask any kind of questions around the mammogram. Again, deep-seated discrete nodule in the breast, etc. All right. Now, we know that mammograms, although reasonably sensitive, will miss obvious cancer. So you can do a mammogram on a patient and the report comes back normal or no evidence of cancer, and yet there is obvious cancer in the... Give me a second again, guys. 1 second again. All right, guys, I need to take a 2-minute break to deal with something urgent. Just hold your... I'll get back to you right away. So just hold on a second. Hi guys, sorry about that breaking transmission again. Back with you. All right, so we're saying that patients who have obvious breast cancer can still go on to have a normal mammogram, right? And so they're not really not a very good accurate diagnostic tool. However, if you look at all the patients who have abnormal mammograms, most of them will ultimately have a benign histology. So most of the abnormal mammograms are not breast cancer, but are other benign pathologies involving the breast. And therefore, in the past, we used to just kind of biopsy every abnormal mammogram as opposed to trying to put some kind of quantification to it. So this imaging reporting system, the BIRAD system, is a method of trying to say, well, yes, these things are abnormal, but they can be they can be categorized into risks that are lower risk of breast cancer and therefore don't need to be biopsied, right? So you might, for example, you might have a Barrett's 2 lesion. It's probably just a lymph node or a fibroadenoma. No real problem. Or you might have a Barrett's 3 lesion, which has a pretty low risk of cancer, but you have to do, you can't do a yearly follow-up. You might decide to do a 3-month repeat imaging modality or different imaging modality, or in fact go ahead and do the biopsy even at that point, right? So we do know that the BIRAD system allows you to be able to know which category of patient needs an urgent biopsy. So for example, if a patient is a BIRADS 4, all of these patients must be biopsied. Obviously, if the patient is BIRADS 5, then all of them must have a biopsy. We do have a BIRADS 6 category here as well, and this is a patient who is known already to have biopsy-proven breast cancer. And therefore, the mammogram in this particular instance was just to try to figure out, well, what else is in that breast? Is this a multicentric disease? Or is this bilateral disease, in which case the treatment will be different, right? So the mammogram is not really done to look for breast cancer so much as to look for breast cancer in the rest of the breast or in the contralateral breast to guide management. Ultrasounds are usually pretty decent at trying to determine if something is solid or a cystic mass, but they're not really approved screening tools. They're more used in the diagnostic workup to distinguish solid from cystic lesions. More recently, we have been using them in our younger patients, sub-35 patients, to diagnose breast cancer, but they're not a real good diagnostic tool and not really an approved diagnostic tool. MRIs are also there in our armamentarium. And MRI, now we're going to use an MRI to diagnose breast cancer. But what we have found with MRI is that it tends to overdiagnose, right? So a mammogram will look like this, showing some increased density to the MRI. It looks awful, looks like that, and it turns out to be totally normal. Just because of edema perhaps occurring in one section of the breast, you might get a bit of abnormality in the MRI. So we actually don't use the MRI to image every breast, right? We only use it for persons who have a higher risk of development of breast cancer, like your BRCA patients, for example, or if you do your risk calculation in your Gale model and your relative risk turn out to be, 20 or 1.2 or 1.5. Then once you have an increased risk of development of breast cancer, then we can utilize mammogram for evaluation and screening, but not routinely in all cases. Of course, we know we can do fine needle aspiration, but fine needle can only tell you about abnormal cells within the breast itself. Sometimes it can't really tell you if it's an invasive cancer. You can't distinguish between a DCIS and a invasive cancer because there's no basement membrane for you to evaluate. Also, fine needles are limited in that they cannot, or I should say in most cases, cannot tell you receptor status. And the reason for that really is that your receptor status is really determined by the percentage of cells, of breast cancer cells that have the particular estrogen receptor. So if, for example, you are estrogen receptor positive, it means that more than 10% of the cells have estrogen receptors in that particular breast cancer. Now, if all you have are a few cells, and the cells you have happen to have the cluster that have a lot of estrogen receptors, you're going to call it estrogen receptor positive. But if you look at a bigger group of cells, an entire more representative batch of cells, it may turn out that only 5% of them have estrogen receptor, and you just happen to be capturing those in your fine needle, right? So it's a little bit difficult to tell receptor status, but some people still report it. And it's a little bit difficult to detect if something is invasive versus just in situ disease. Fine needle seems to be more useful in patients who have obvious breast cancer. So there's a fungating lesion in the breast. You want a quick diagnosis. A fine needle can give you an almost immediate diagnosis when it is obvious. You just wanted something on paper to say it's breast cancer. But in a rigorous diagnostic workup, we prefer to use cores because they give us entirely more information than a fine needle can give you. It can tell you about architecture. It can tell you about basement membrane and its invasion. It can tell you about receptor status. And it can tell you about the specific pattern of the histology, so you can get better details on tumor grading from a representative piece of tissue compared to a fine needle. In terms of other forms of biopsy, we can do open biopsies, but we try to avoid it as much as possible. Because once you do an open biopsy, when you come to do the definitive surgery, your options are going to be restricted by the fact of having a scar that needs to be excised in the definitive surgical margin. So if at all possible, we do a core to get to the diagnosis. Because an open biopsy is going to result in more than likely 2 surgeries. Because you're going to have to do a surgery to do the biopsy and then another surgery for the definitive treatment of the cancer. So we tend to avoid it and just not the open biopsy. These are some of the commonly asked questions that might come up as far as the diagnostic workup, which is when will the fine needle be appropriate, when will the core be appropriate, incision, excision, etc. Of course, we also have to talk about something like hook wire localization, or it should be I-125 seed localization. Basically, it's a radioactive form of iodine that we can inject or place in an abnormality, a mammographic abnormality, which you can then find at surgery by using a guide counter to detect where the radioactive seed is. Or replace a wire inside of the lesion and then use the wire to guide us to remove the lesion. These are now when we talk about removal or biopsy of non-palpable lesions. So we can't feel it, we can't see it. We can just stick a wire in it on a mammogram or an ultrasound, and then the wire will guide us to the removal, which you can then send that excised specimen for re-imaging and then for pathological analysis. In terms of staging breast cancer, you want to determine the extent of spread, because that will tell you how to counsel the patient as far as what to expect, what is the prognosis, and it will tell you about some aspect of treatment as well. And you have various staging systems that you can employ in order to get the answer that you require. Hardly anybody uses a Manchester system anymore. It is a pretty blunt tool, frankly, but it's still a useful tool. If that's all your brain can remember, then at least have that filed away in your brain, so that the more complex systems tend to elude you under pressure. But at least if you know that there's a disease in the breast, or there's at least if you know if it's a stage 3, the skin is going to be fixed, the mass or the axillary nodule is fixed. And then, of course, grade 4, you have distant spread of disease. The more complicated TNM systems now start utilizing tumor size to tell you about the T stage, T1, T2, T3, and T4, where extending through the chest wall. And when you start getting into lymph nodes now, you can get into N1, N2, N3 disease, and then M remains the same. The more complicated staging system, like your 2010 TNN AJCC system, this is now difficult to utilize in an exam setting, because you will now be required to know how many positive nodes do you have in the axilla. Less than 3, N1, N2, 3 to 7, N3, 7 to 11, and so on. So if you don't know the number of nodes, by excising the specimen or by doing a guided biopsy of these lymph nodes on the ultrasound, it's hard to say accurately what the AJCC staging is for the particular patient. And so I find that this particular middle ground is useful to keep into your head, knowing this TNM system where you can speak to tumor size and speak to nodal presence and so on in order to get the N1, N2 entry stage. So this is a useful one. AJCC, a little bit more complicated than you absolutely require to know, I think. How do you stage? Well, you can examine the patient. You can utilize all of your radiological tools. And of course, you can always do sentinel lymph node biopsy to get the lymph node status of the patient. All right. You may be asked this because we do sentinel lymph node biopsy. How it is done? Well, we utilize a double tracer for the most accurate diagnosis, meaning we inject a technetium labeled sulfur colloid along with a radioactive, which is radioactive, along with a blue dye, isosolvent blue or methylene blue, into the tumor or in the subareolar area or in the intradermal area. It doesn't even matter where you inject the substances, right? And then we take the patient to theater, we deal with the breast however we want to deal with it, however it's indicated by the stage. But the way to deal with the axilla, and this is now an axilla in a patient that has no palpable lymph node, we take out the node that is radioactive and blue. If you can identify a radioactive node, a hot blue node, then we can take it out and analyze that node. If that node is positive, it usually indicates that the axilla is positive. It's just giving you an axillary status. If the axilla is positive, it means that you're going to have to treat more aggressively as far as including the axilla in your radiation field or more aggressive chemotherapy, and you have to counsel the patient that you do have stage 2 disease or perhaps stage 3 disease. And so prognostication is going to be very important. In the good old days, we used to, when we find a positive axilla, we used to take the patient back to theater to do a complete axillary dissection. Or we would keep the patient in surgery, do a frozen section on the node, and then complete axillary dissection if it is positive. Nowadays, we don't do that, right? So just to clarify, nowadays, even after a positive sentinel lymph node biopsy, we don't generally do axillary clearance. We usually just accept that the patient has a positive axilla, and then this is going to guide the treatment, but it doesn't mandate a new operation to take out the nodes out of the armpit. Because the whole objective here really is to minimize the amount of surgery we're doing, because we would have been able to identify that more axillary work results in more lymphedema, more nerve injury, more vascular injury, and so on. So we try to avoid axillary structure injury. At the end of the day, though, what you're going to be ended up with is something looking like this. And I should guide you that this is just a made-up slide, right? All I've done here is superimposed a genetic panel, a gene panel, on top of a regular H&E slide here, right? So these are two separate things. I just combine them for effect. So we look at the tumor under the microscope with H&E stain, along with every other stain that we can use. And we also need to get a genetic profile of the cancer, because what we're now discovering is that breast cancer is not just one disease. Breast cancer is many diseases kind of lumped together. It just happens to occur in the breast. And it behaves differently based on the genetic profile and based on the genetic appearance, the histological appearance. And so trying to figure out which of the breast cancers you have is going to guide treatment, is going to guide your prognostication for that particular patient.
So a question
Now,
quickly. So just to confirm, a radioactive node automatically means a positive axilla there. Yes?
come again, what was the question?
A radioactive node means a positive axilla.
Okay.
Yeah.
No,
No?
that's not true. No. So let me explain a little bit more then, since there's a confusion. So in a sentinel lymph, the philosophy of sentinel lymph node biopsies, right, is that breast cancer spreads in a very orderly fashion, in a very stepwise fashion. It spreads from the breast cancer, it invades the lymphatic channels once it can get below the basement membrane, and it spreads to a node or a group of nodes, usually in your level 1 of your axilla, right? Meaning below the pectoralis minor. That's level 1. Behind pectoralis is level 2, and above is level 3. All right. So in this level 1 group of nodes, the cancer is first going to spread, and then it's going to spread from that node to the other nodes in level 2 and level 3 and contralateral nodes and so on. That's how breast cancer spreads. It's pretty orderly in the way it spreads. So therefore, if you can find that level 1 node to which the cancer would have spread if it is going to spread, then you can make some comments about what's happening in the rest of the axilla. So the sentinel lymph node biopsy procedures are aimed at finding this node to which the cancer would have spread if it were going to spread. So if you find a node and it does not have cancer in it, it means the axilla is negative. If you find the node and it has cancer in it, it means the axilla is positive. The techniques are only geared at finding out where this sentinel is, where this sentry, where this guard is. It doesn't mean that the fact that you identify a sentinel node by radioactivity or it being blue, that it has cancer in it. This node has now to be analyzed to see if indeed it has cancer.
Okay, sir, got it. Thank you.
All right. Any other question on that sentinel lymph node story? Because depending on what you're reading, you might have read, if you're reading older literature, that if you have a first of all, you might have read that we do frozen section on sentinel lymph node. Right? That's how we used to do it back in the day. We took out the node, we did a frozen section, the patient is still asleep, we analyze the node. If the node is positive, we take the patient, we complete axillary dissection, right? Or we do regular preparation of a node, and if the node turns out to be positive, we take the patient back to theater for completion axillary clearance. That is no longer done. I'm just mentioning those things to say that, yeah, you might have read that, that is not done anymore. We now just accept that the node is positive and we treat accordingly. Or accept that the node is negative and we treat accordingly. We do not do completion axillary clearance. Now, to confuse you a little bit more, yes, Robin?
Okay, sir, not quite the same question, but in terms of the preoperative.
All right, hold your question a little bit. I want to finish one quick thought before you ask your question.
Okay.
And the quick thought is that it may emerge, or it is emerging, that there is a group of patients or a subset of patients that would benefit from a completion axillary dissection after a positive sentinel lymph node biopsy, right? So that is an emerging group of patients. It turns out to be a group of patients that is younger, with more aggressive histology and so on, aggressive appearance on histology. But that is an emerging part of the science. As of right now, what you need to know at the undergraduate level is that a sentinel lymph node, but a positive sentinel lymph node does not require an axillary clearance. Yes, Robin, your question.
Yes, sir. So in terms of preoperatively, you do your imaging and your biopsy of your breast lesion. Do you do any biopsy preoperatively of the lymph nodes, or do you go to OT with your clinical assessment and then do the biopsy in OT?
Okay, that's an interesting. That is what is being done now. Because what you would do if you have a breast lesion on ultrasound, and you also have an axillary node on ultrasound,
Sorry, sir, you
can
broke
actually
up.
core both. Sure, yeah, man. I'm saying if you have a breast lump or a breast abnormality on ultrasound, and you can see that lymph node as well on ultrasound, then you can actually do a core biopsy of both the breast lesion as well as the lymph node, ultrasound guided core of the node. So you can preoperatively know that this patient has stage 2 disease.
Okay, got it, sir. Thank you.
Currently, right? So whereas it's not generally what is done in every case, that is what is emerging. We're now doing ultrasound guided lymph node biopsy to be able to tell what the nodal status is. But if we didn't do that, and the node remains non-palpable, we can utilize some of these other techniques like your sentinel lymph node and double tracer to find the node. Right?
So
So a
currently,
sentinel lymph node assumes that the patient is clinically node negative, which includes also ultrasound node negative. Because otherwise you would have just biopsied it.
okay, got it, sir. So for the clinically node negative, you don't do anything preoperatively. You go in and do your sentinel, and then
You
for
can do a
those
sentinel node.
and
Or
or the
forget the
full
sentinel and
clearance,
just do a full clearance. That's an
yeah.
option too.
And then for
Yeah.
those that preoperatively you do detect a node, you can biopsy it like under ultrasound guidance.
You could do it on ultrasound guidance. And if it's positive, you can just go ahead and plan for how you want to treat the axilla.
Okay. All right. Thank you, sir.
All right. So in terms of treatment, the objective really is to get rid of the cancer. You're trying to prevent recurrence of the cancer. You're trying to extend the patient's life, right? So life expectancy is what you're aiming for. In terms of how you treat it, local and regional treatment is going to be surgery and radiation, and systemic treatment is going to be the other things: chemotherapy, hormonal therapy, immunological therapy, and so on. You should note that for patients who have stage 1 and stage 2 disease, these are considered early stage breast cancer. For early stage breast cancer, the aim, your intention to treat, is to get cure. For patients who have later stage breast cancer, stage 3, stage 4 breast cancer, although you would love to think you're going to get a cure, the best you can hope for in most cases here is palliative treatment, meaning trying to allow the patient to have the longest disease-free survival possible. But we know that it's hard to cure stage 3 and stage 4 disease, but cure is well possible and is the objective in early stage or stage 1 and stage 2 disease. How you define a cure is a little bit of a moving target. And if you have disease-free survival 5 years post-diagnosis, we allow ourselves to start thinking about a cure, right? You never quite get there, but we are more confident if you have gone 5 years with no disease, that it is less likely that you will come back with recurrent disease. Having said so, we did mention before that your lifetime risk is about 2% per year. So you can get recurrent de novo cancer. Even without having recurrence of the breast cancer, your risk of cancer is increased in that particular patient. So something to bear in mind. All right, so early stage 1 or 2, cure. Later stage 3 and 4 is treatment we're after to extend life. So I want to drill down
Sir,
into the...
I'm sorry, I have a question. So
yes, go ahead.
you're saying that for stage 1 and 2, which can be cured, they have a cure is considered as a 5-year disease-free survival post-op.
I'm
And
saying
you're saying
that
that
although that I'm saying that definition is kind of loose because you can never quite define an absolute cure, right? But I'm saying after 5 years, if you have had no disease, then we allow ourselves to start suggesting that okay, maybe there's a cure. Yeah.
So
okay.
post-op or
And
post-diagnosis? 5 years post-op or post-diagnosis?
Post-treatment.
Okay.
and you also said
Because
something about
you can be diagnosed and not get treated for 4 years. It does mean, so yeah, it's post-treatment. You've gone 5 years post-treatment, disease-free post-treatment.
yes, sir. I also said something about 2%. You were saying that they now have a 2% risk after the surgery or after treatment.
Right. I'm saying that once you have had breast cancer, your risk for development of breast cancer again is between 1 and 2% per year. So if you live 10 years
Okay.
after the diagnosis of breast cancer, you are 20% likely to get 10 to 20% likely to get breast cancer again. Even though it is not the original breast cancer, you could even get cure of that cancer, right? But for whatever reason, because of your particular biology or your lifestyle choices, your body's at increased risk of breast cancer. That's not going to go away just because you've treated one of the breast cancers you're going to get.
Okay, thanks, sir.
So there has to be a distinction between recurrence of the breast cancer and now new breast cancer development. With me?
Yes, sir.
All right. Okay. So in terms of surgery, we have to look at the various options for surgery. We know that the options really are either a partial mastectomy, also called a wide local excision, or mastectomy, right? But we then need to break down these broad definitions a little bit more. So wide excision assumes you're removing the involved lump, that you can find the lump, you're taking it out, and you want to take a penumbra, a normal margin of the breast, 1 to 2 centimeters around the cancer, right? Very important to note that once you're doing wide local excision, we must give radiation of some sort to the remaining breast. So we're either going to go external beam radiation or in more recent time, intracavitary radiation. But the rest of the breast must be irradiated if you're going to do a wide local excision. And that seems to be a lot of the reason why we don't do it much in Jamaica, because you have to be able to access radiation within about 6 months of the original surgery, or your local recurrence risk is unacceptably high. All right. So after you have dealt with the lump itself, you must address the axilla in some way or the other. So you're either going to do a standard level 2 dissection, or you can do a sentinel lymph node biopsy. So what you're doing in the breast is kind of independent of what you're doing with the axilla. We don't use terms like lumpectomy, because lumpectomy is a term utilized for benign disease. It assumes you're just taking out the lump, right? It doesn't speak to the fact that you have to take away a wide margin of normal breast tissue, 1 to 2 centimeters around the lump. So so lumpectomy is reserved for benign disease, and we talk about a wide local excision when we're talking about malignancy. As far as the options for mastectomy simply means you remove all the breast tissue, and I put all in brackets here because you can never really get there. It's unobjective. Oftentimes we leave about 5 to 10% of tissue in the axillary tail of spines, on the skin, in your skin flaps, on your chest wall. You don't ever really get 100% of breast tissue. If you're going to do that, you're going to risk a very, very thin flap, which can become necrosed, right? So we accept that you can't do a complete mastectomy, but that is the objective. Now, the modified radical mastectomy is still the so-called current gold standard. However, you should know that what we call a modified radical mastectomy is not really that, and it's really a modification of the original modified radical mastectomy. The radical used to be something we did a long time ago. We take out the breast and we take out the skin areola, everybody. We take out the pectoralis muscle, we take out some of the ribs if necessary. That has not been done for 50 years because really, right? So we modified that to a modified radical mastectomy, which is where we took off the breast skin, we divided the pectoralis minor and removed the nodes in level 1, 2, and 3. That's a modified radical mastectomy. Currently, we don't do that. We have modified it further, where we don't cut the pectoralis. We now just retract the pectoralis minor and remove the nodes behind that up to the level of the axillary vein. And that is a modified radical mastectomy. We could also do something called a simple mastectomy and then figure out what we're doing with the axilla. Or we can do a skin sparing mastectomy, which is where now we're leaving the envelope in place. We're taking out the nipple and the areola, leaving the rest of the skin of the breast, and taking out the breast, right? Or we can do an areola sparing where we're taking the nipple, leaving the areola, and taking the rest of the breast. Or we can do even a nipple and areola sparing mastectomy. So we can do various things with mastectomies as long as we're taking out all of the breast. So the typical modified radical looks something like this. I'm sure you will agree that it is not attractive. Or we could do something like this, a partial mastectomy or wide local with auxiliary work. Now, the challenge with the wide local sometimes is that it leaves you a little bit imbalanced, shall we say, because then now the breast here is smaller, and then this one still has a fair amount of ptosis, and therefore there's a certain amount of lopsidedness to the outcome, right? So we have to figure out who really can get a wide local excision. Does size matter? Well, yes, in a relative sense, because if you have a 5 centimeter lesion in a size B cup, and you decide you're going to do breast conservation and do a wide local excision, that is basically a mastectomy, right? Whereas if it's in a size H cup, then you can do a wide local excision because nobody would even know that some breasts went missing, right? So it does matter in an absolute sense. What matters is what is the size of the lump in relation to the overall size of the breast. What determines if you can get a breast conservation is if at the end of doing a proper oncologic surgery, you still have something there that can legally be called a breast. If that is the case, then you can generally do breast conservation. If what you're left with is ugly and looks worse than it would have looked if you had done a proper mastectomy, then you might as well just do the mastectomy. So we have to have not only the right size, the right relative size, but we have to be able to get good excision margins. And the tumor has good favorable histologic grades. We tend to do it in an older patient because in a younger patient, there's more time for the development of new breast cancers. So the older patients tend to benefit more from breast conservation. As I told you before, we must be able to get radiation treatment within about 6 months of the original surgery, or it's not safe to do. And of course, you have to find a way to address the axilla with whatever technology you have available to you. And then post mastectomy, now we can do some kind of reconstruction, either non-surgical with external prosthesis, or we do some kind of implanted prosthesis. External prostheses are made of various things that we have lying around the house, or we can utilize the silicone prosthesis. As you can see, they have a better look and feel of breast tissue, and these ones are supposed to be flesh colored, except it's the wrong flesh. And these are just placed inside of your hosiery to balance the appearance of the upper torso. Or we can implant prostheses, synthetic prostheses, saline silicone implants, or we can do something else. We can do a mastectomy and then put in a prosthesis here. I think we can all agree that there is still a problem in that the new breast is in the right position now, the so-called right position, whereas the normal breast is now much lower because there's a fair amount of ptosis occurring in this normal breast, right? If you draw a horizontal line here, you can see that the breast is sagging way down. So what do? We do something called a balancing procedure, where we do a mammopexy here, areolar reduction, and a breast lift on the side that is normal, and then put in a nipple areolar complex from skin harvested elsewhere that has a dark texture, or we can use tattoo ink to get the right color of the nipple and areolar complex. That might have to be refreshed from time to time. And as I'm sure, once the swelling and so on settle down here, you'll find that the patient has now balanced appearance to her breast. These are some of Dr. Venugopal's pictures for some of his work. Apart from putting in these internal prostheses, we can also do a tram flap or a VRAM flap or other kind of flap procedures that brings mass tissue from elsewhere, latissimus dorsi, the rectus abdominis, up towards the chest and to fill out the space and create a mound in the particular area. So flap reconstruction is something that we do. So you have to know something about it. The tram flap in and of itself will also result in reduction in your abdominal panus. And so a lot of women will go for this procedure, but it's a more invasive, more horrendous procedure to do. Obviously, this patient has an areola sparing mastectomy with axillary lymph node sampling by sentinel node. And you can see that the breast is not really the breast. What we've done is brought tissue up from here, the lower abdomen, and brought it all the way up to the breast. Let it settle, and then we can go back and then construct a nipple out of whatever local tissue we have here, or transfer some other tissue in place to create a nipple in this particular location. And of course, the patient belly is completely flat after the procedure because we have taken away the fat and excess skin from the lower abdomen. And then, of course, we reconstruct the family. The patient's family is often impacted by breast cancer as much as the patient, and therefore there are other support groups that are available to deal with the patient and their issues. In terms of the prognosis, we know that the overall prognosis is about 65% at 5 years, but at 10 years it falls off. Now look at these numbers, and these are a little bit better than I've represented here, but you can see that for your stage 1 and 2 disease, there is a pretty high cure rate, and it doesn't change very much at about year 10. It reduces about 5–10%. But once you are stage 3 and stage 4, you're now below the 50% threshold, and your likelihood of developing breast cancer is going to, of surviving breast cancer decreases dramatically, and will decrease even further at 10 years in terms of survival statistics. So it's important, important stuff there. Of course, the question is, can you prevent breast cancer? Well, yes, you can kind of reduce your risk. You can't quite prevent it, but you can change your modifiable risk factors. Obviously, you can't change your unmodifiable risk factors. You can't change your gender, but you can enter into childbearing earlier if you want. You can have more kids if you wish. So you can modify your modifiable risk factors as much as possible. You can less drinking, you can less smoking, you can screen. We can also try to prevent development of overt breast cancer or late breast cancer by early detection of breast cancer, by breast self-examination, which, by the way, doesn't work. I said that it has not been shown to reduce the risk of breast cancer and breast cancer mortality, breast self-examination. So we don't really invest much in time and money into trying to teach it anymore. Is useful, and we do it at least every 3 years for the younger patients, and then every year for the older patient over 40. So this is a little controversial. I know that my Trinidadian colleagues will tell me that they start their screening, mammographic screening, at age 50. That came in an MCQ a couple of years ago, and it created a bit of controversy. So whereas we still in Jamaica, for example, recommend 40, in Trinidad I think it's 50. Barbados, I think it might still be 50 or 40. I can't remember Barbadian screening age. But it's different in different parts of the Caribbean. And even in the US, it's now changing from 40 to 50, because we're finding out the detection rate between 40 and 50 is very, very low. And therefore, the accuracy falls off very, very much in your early years. As you get older, the breast becomes less dense, the detection rate goes up quite substantially, and you can now justify screening. In terms of some of the controversies in breast cancer management, I might have mentioned some of them, but you can tell me if you want to delve into the controversies. it's not really strictly necessary, but we can explore some of them if you want to explore them. All right, I want to stop at this particular point in time. What do I have coming up next? Benign breast disease. Okay, let's leave it there for now. About an hour and a half anyway, of any lecture or any tutorial. So let's leave it there for now and take your questions. And then we can also look at some of those MCQs and you can tell me if you agree or disagree with my answer, if you have other answers. Yes,
Sir,
Good afternoon. I just want to confirm we start at 40 years old in Jamaica for
yes.
screenings.
And the reason why that is so is because we still are not screening as much as we should in Jamaica. In fact, 60% of our breast cancers are diagnosed at stage 3. So clearly, we are not we're not doing as much as we can as far as screening for breast cancer, which is why the latest recommendation from the local panel is still to offer it at age 40, although we appreciate that the detection rate is not very good at age 40. But since we're so bad anyway, we can't increase that age as of right
now. Thank you. One more question. So
yes.
you said we don't do axillary clearance anymore. And that the old literature would say if the sentinel node was positive, then you would move to axillary clearance. Correct? Right. Is that going to be?
So I'm clarifying that we don't do axillary clearance following a positive sentinel lymph node biopsy, right? But I remember I told you about the minority report, but you don't have to mention the minority report for your purposes. For your purposes, it is not done after axillary clearance. The minority report for persons who want to get in honors and distinction discussion is that, yes, there's a tiny subset of patients who may still benefit from axillary clearance. If you recall, for those of you who are reading studies, they had actually aborted the study when they discovered that you didn't need to do axillary clearance and you're causing all of these unnecessary axillary morbidities. So they aborted that study and stopped doing axillary clearance following sentinel lymph node that was positive. However, as it turns out, some of these women who didn't do axillary clearance this is not the minority, the Caucasians if you don't want to hear this part, some of these women that went on to develop axillary disease, right? So the question is, should you have done axillary clearance in these women? And so there's this tiny subset of young patients with aggressive histology that should or perhaps should get axillary clearance. That is still being elucidated in the literature as we speak. Who is in this tiny subset of patients? But for your purposes at an undergraduate discussion level, once you have a positive sentinel node, it doesn't mandate axillary clearance. It mandates that you have to address the axilla by altering your chemo and radiation regimes, but not do surgery after.
Okay, thank you. Yes, but since we won't get to do an ASCII, I was just making sure that this newer approach is new to me, is what is going to be reflected on the questions.
I think so. I mean, the approach is 10 years old. I would like to think that we are going to set questions that are current based on the current literature. So it's not that new. It's not that new. It's about 10 years old now.
All right, thank you, sir.
All right.
So question. So the screening mammogram at 40 years or 50 years, right? That is for all women that age. What about if you have persons who have a strong family history? Could you just confirm for me the age at which you would start those? Because I know it's a little bit earlier.
Sure. So now here's where your model comes in, right? Because what you would then do for that particular patient is run them through one of the models, right? Plug in all of the various factors, the age of menarche, their age, how many children they have, or how many pregnancies they took to parity, which member of the family has had breast cancer, what the histology look like, etc., etc. So you plug in all of these variables into the one of the risk models. The risk models will then tell you, okay, you have a relative risk of breast cancer of 5. Therefore, you cannot start screening at the standard screening. You will need to start screening at age 35. You will have to start screening at age 40 by doing an MRI, for example, as opposed to routine mammographic screening. So when we talk about these screening protocols at 40 or 50, what we're talking about is an average risk patient. Once you're not an average risk patient based on your risk calculation, then you have to do a unique screening based on your risk profile.
Okay, so thanks. So then therefore so then it would depend on what the model says.
Correct.
There's no set age for
Correct.
someone who has a strong, okay, all right, got it. Thank
Right. So most persons with a strong family history and perhaps one of those histologic variations or genetic risk, most of those persons are going to get MRI screening anyway. They're not going to get a mammogram. They're going to get MRI every year, mammogram every year. So 6 months, every 6 months, some imaging modality is going into that breast. Right? So you're going to do mammogram in January, MRI in June.
Okay, so
And run that every year.
That was the
right?
staggered treatment.
Correct.
Yeah.
Correct. So you don't go a whole year without evaluating the breast. But all of that is going to be dependent on your relative risk calculation.
Okay, thank you.
All right.
Sir, I have a question. The relative risk calculation, the score that you get after you calculate, what score do you usually recommend that a patient start screening?
Not following you. Ask question again.
All right, so just now you gave an example of the risk score being 5, right? And you said that this patient should start screening. I'm asking, what's the usual risk score that you would recommend a patient to start screening? I don't know if I'm clear.
Okay, let me try to clarify. So that 5 is a made up number. Don't put any stock in that particular number, right? What I'm saying, if you look at for example what we said earlier about MRI screening, right? You don't have to get as high as 15% or 20%. Look at this one. Look at this one here. For example, the American Cancer Society risk criteria for MRI screening, right? Once you start getting the risk calculation of 20%, that's 1.2 relative risk or 1.25 relative risk, they're recommending MRI for screening for those patients, right? So it has to do with what you put in the model, choosing the right model in the first place, putting in the correct variables in there, and once you get a relative risk calculation that puts you at a higher risk than the general population, then your methodology and your onset of screening is going to change based on the risk calculation.
Okay, thanks, sir.
All right, let us, while you're thinking about your other questions, let's look at those MCQs that we did. And as I tell you before, there's a prize. Oh boy. So let's go through. Everybody's clear on the answer to question 1? So we'll let you mark yourself, Question 1, which of the following are true of breast cancer? What answer people get? Somebody give me an answer. A? All right, no problem. Anybody have a different answer? All right, no different answer, so we'll go with A then, that's majority. What about question 2? Risk factor for breast cancer include? D. Okay. Anybody have a different answer? No? All right. Majority decision. How about question 3?
I can say A. I think I'm staying with A. I really want this to be, but I don't feel like.
Richard says it's B, so does Shade. Anybody have any different answer? No? All right, cool. Moving along. 4.
So you have.
Pardon?
What are they asking?
All right. So question 4, somebody says A. Anybody agrees with that person?
I can say
Right. Remember we said earlier that we cited the example of Jamaica specifically, and we said that it's 40 that we start here. So if you see this here and we're talking about the entire Caribbean, it can't be that it applies to the whole Caribbean. There are certainly some countries in the Caribbean where 50 is the age, but others we start at 40. So this can't be a blanket true statement. Right, now B, we spoke about the reduction. Yes, it's about a 30%. When you consider all of the various subgroups, it's about a 30% risk reduction. So B is a more appropriate answer. That's a little tricky one, but B is a more appropriate answer there. How about 4? What's the answer in 4? Sorry, it's 4 we're doing? Yes. That was question 3 we were discussing.
Okay,
Question 4.
clarifying that B is the more appropriate answer for 3.
Yes, that is correct.
Okay.
For question 4, okay, that's a little controversial. Some people have A, some people have B. All right, well, you want to argue with each other then? Which of the following is not necessary when a patient first presents with a breast lump? Who wants to defend their answer?
Sir, I was thinking along the same lines as what Richard said, your triple assessment, which involves your clinical examination, your imaging, and your biopsy in terms of the necessary investigations. So I didn't put chest x-ray as something that absolutely has to be done, especially if you're thinking it's localized to the breast.
Mm-hmm. So you don't think it's necessary? Okay, no problem. I agree. Chest X-ray B is the one that's out. All right. 5 in breast cancer. What you have? A. All right. I'm good with that. How about question 6? All right. I see A. I see C. Okay. Let's see if we can clarify that then. That seems controversial. Which of the following is true regarding adjuvant treatment for early breast cancer? Who has A? So early breast cancer is somebody has radiotherapy is indicated after breast conserving surgery only if greater than 4 nodes are positive or tumors are close to the resection margin. Okay, so clearly we spoke about this, right? And we had said that every patient who gets breast conservation surgery requires radiation treatment of some sort. So that would invalidate that answer. So C, most persons seem to have C that combination chemo reduces recurrence and improves survival in selected patients. Yeah, that's true. I'm okay with that. 7. What you have for 7? I see CD there. Gaspar, what do you mean by that? Not quite sure if it's CRD. All right, so 7 is D, right? What's 8? Okay. Sabrina has A. Sorry, which question are we answering? 8. I see A, I see D, I see C. Okay. So this is now a very interesting one. All right, cool. Let's ventilate it. Let's go down. Let's drill down into 8 a little bit then. So tell me who was A? Tell me how do you justify your answer in A? Nikolai. Nikolai Johnson.
I'm here, sir. I'm just not sure the best way to explain it.
What do you mean?
It was just a thought in my head that if you were able to do a successful surgery, getting as much of the tumor as possible, especially with better margins early, then I think that would be better than conservation with other means of treatment like radiotherapy and such to come afterwards.
But they won't have a breast.
True, but
Sir,
I was only thinking of treatments, not necessarily best for cosmesis.
All right, so that's a very, very important point you have raised, and perhaps I didn't emphasize it enough in looking at breast conservation treatment. What we have found is that the breast conservation treatment can only be offered if it does not decrease your survival. It doesn't give you a survival disadvantage, right? So if you do it properly, breast conservation treatment and mastectomy, by doing it properly, I mean you select the patient properly as far as the categories we spoke about, and you can give radiation treatment to the breast within 6 months. Once you do that, the outcome is going to be the same ultimately. What is different is that there's a slightly increased chance of local recurrence in the ipsilateral breast. However, if that patient is available for follow-up, and that's another criteria, if a patient is available to be followed up and you follow them according to the appropriate protocol, you would have detected that recurrence and then you would have been able to do other surgeries like a mastectomy anyway. So you would have been able to, in the process of that, if you apply that rule all the time, you'll be able to save a lot more breasts with no increased risk of the patient dying from breast cancer. So the only risk in the breast conservation surgery done well is that there's a risk of recurrence and therefore a risk of repeat operation.
Oh, okay.
So otherwise there are equivalent outcomes. But I'm happy you raised the issue in the way that you did. All right. So chemotherapy can be used safely in the first trimester of pregnancy. Somebody had B. Who had B? Well, obviously we use chemotherapy in the second trimester, right? So that would not be an option. It's only used in the second trimester of pregnancy, perhaps the third, but not in the first trimester where you're getting organogenesis there. And C, radiation should be given to all male breast cancer patients after mastectomy. That is actually the answer. And here's why. Patients who are male who get breast cancer, and this is a generalization, usually it's, apart from being more aggressive, it usually is that it's a later stage breast cancer, because patients with breast cancer usually present, male patients present much later, and they don't have much breasts to speak of. And therefore, usually the vast majority of them already are presenting with a stage 3 disease, with or stage 4 with 3B with fungation or invasion of the pectoralis, which is right below the skin, right? So the vast majority of them are going to require radiation because of the stage at which they present. All right, 9 quickly. What is about 9? Okay, not controversial. 10. What about 10? Okay, so a little controversy here. I see A, I see B. Interesting. Let me go back to the question. See why this. So B is a more appropriate answer here. Because we know that breast cancer spreads to the bones, because we know breast cancer spreads to the bones, if you present with back pain and or radiculopathy, then you have to promptly investigate in order to prevent a complete spinal collapse and permanent paraplegia. So that is really what is the urgent point that we're trying to raise in this particular question. All right, who got 1 out of 10? Anybody? Anybody got 2 out of 10? 3, 4, 5? Richard, how much you got?
Good afternoon, Dr. Paul. So I have a question about number 10, right?
Yeah.
So we already know that one of the major places for metastasis of breast cancer is bones, right? So we would have been doing our skeletal surveys and been monitoring this patient for metastasis and probably, treating them prophylactically for same, right? But in the immediate setting where you have, let's say you would have already had the metastasis, but you don't have the complications of, for example, as you said, the radiculopathy, right? But you do have a hypercalcemia. Don't you want to treat that first?
So here's the thing with these type of questions. The question is, what is most right and most urgent, right? And what is most relevant in this particular question, Richard, is that once you see somebody with back pain, new onset back pain, that is an absolute red flag. Stop the presses. This back needs to be investigated immediately, because what you hate to have happen is that a patient has spinal mets, you ignore or delay the investigation, the patient go on to have a collapsed vertebra, a crushed spinal cord, and it's permanently paraplegic. So what the question is trying to communicate here, I think, is the urgency with which you need to just respond to this issue of back pain. There's always degrees of right or wrong in some of these questions as it gets more complicated. I'll put that one in the last, make it more complicated. But what we're really trying to communicate there is that this is an urgent matter that needs to be dealt with and or radiculopathy. All right, I assume you got more than 5. Anybody got more than 6? More than 7? What? What about more than 8?
Wait, sir. Sir, what was 1 and 2?
Come again?
I missed those. What was 1 and 2? I missed those. So 2
The answer
is
to 1 the answer to 1 was A and to 2 was D, I think.
D. Okay.
Anybody got 9? Okay. What about 10? Anybody got 10?
No. Okay.
Nobody got 10? Why does Daniel want the prize shared with her? Because you asked, of course. All right, so we have prizes for Shade and Afia. A phone credit for you. How you gonna get it? And as a matter of fact, there are digital credits, yes. All right. Send me your send me a WhatsApp message and I can probably WhatsApp you the number or something. All right. So that's only the persons who got 9. So you have the digital credit here. You send me your contact by WhatsApp and I will send you your number. I'll do that later on this evening. Let me tell you my number. All right. All right, guys. Have a wonderful day. Good luck in your exams. I think I might see you in there.
Oh wait, Dr. Powell, one quick question.
Yes, sir.
Could you return to the slide that showed reduction in mortality with early imaging? With mammography, sorry.
Right. So as I was pointing out to you about that slide, the numbers there than those slides represented.
Oh wait, you went out for
Right?
what were you saying?
I'm saying the current numbers are a little bit better than represented in the slides.
Oh, okay, understood.
Right. But the essential point that we're trying to make in that particular slide is that the numbers are really not that good. So whereas it is the best available technology for routine screening, it's not a good technology, right? And it's awful in younger patients. And as you get older, it gets above 30%. On average, it's about 30%. But as you get older, it gets early from the 70 to 75, it's well up in the 40s. But on average, it's about 30% overall.
Okay.
But as you get for young patients, the results are below 20% for risk reduction.
Understood.
Or death risk reduction. All right.
Sir, I have a question. Sir, I have a question. For the male for the male patient who had breast cancer and we selected that we would give him radiation. Could we give him chemo radiation as well or just radiation?
No, we'll give chemo as well. The issue was not really about the chemo so much as to whether there was going to be radiation as well. Okay. So generally, in most patients who get all patients who get chemo, who get radiation therapy, would also be a candidate for chemotherapy.
Okay, sir.
If they can tolerate it, or other hormonals or so on. All right, Joel. All right, guys. So if you have any other questions, shout me know, and I'll see if I can get to respond to them. If not, good luck in your endeavors. I will see you when you come as interns in a little while. All right, guys. You're welcome.